difficulties over here today. So welcome, my name is Jennifer Lloyd. I'm the philanthropy officer for Northern Light Health Foundation, and it's my pleasure to turn the evening over for a welcome from the president of and senior vice president of Northern Light Health and president of Northern Light Eastern Maine Medical Center, Randall Leary.
Thank you, Jenny. And good evening, everyone, and welcome. I am the president of Eastern Maine Medical Center and also serve as a senior vice president for Northern Light Health. And on behalf of the Medical Center and Northern Light, I really want to welcome you and thank you for being here with us tonight, particularly for all the work that you're doing to help serve our patients. We couldn't do it without you. I am incredibly fortunate and proud to lead an organization that provides world-class cancer care close to home for Mainers. Really no question there. We have an amazing program. Very fortunate to have it. Our team includes dedicated experts in several fields of oncology. They work very closely with a number of fellowship trained surgeons, and really working together in a team, we deliver coordinated, compassionate care, all here, all available, and all under one roof. Your support really makes this possible and ensures that not only yourself, but your family, your friends, your neighbors can rely on quality care that's close to home. And should they ever face a battle with cancer, it's incredibly important to have these services local and available and close by. So you're an inspiration to me and to all of us at Northern Light Health. We couldn't be more grateful for your commitment to joining with us to defeat cancer. And we believe that is possible, making so much progress every year. On behalf of myself and Donna Bohm, who's our system leader for Northern Light Health Oncology Service Line, and also the Associate Vice President of Oncology at the Lafayette Family Cancer Institute, who is also joining us tonight, I want to just say welcome again and thank you all for everything you're doing. It is very much appreciated, and we couldn't do it without you. So thank you.
Thank you so very much, Rand. It's my pleasure to introduce someone who is probably not unfamiliar to many of you. If you reside on MDI, you've likely heard the name Bill Horner. And so he is here today to start us off with breast cancer, a look back. Dr. Horner has had a tremendous career in the field, and so he's going to take us down memory lane and share with us a little bit about his experience. So, Dr. Horner, first, can you just tell us a little bit about yourself and what brought you to this field of medicine?
Yeah, thank you, Jenny, and thanks for this opportunity to rejoin some of my colleagues who I haven't seen for quite a while, particularly Susan and Kim. Really good to see you, although I can't see you at the moment. Hopefully that will improve. In some ways, I feel like the ghost of surgeons past. It's been a while since I retired, but in my retirement, I've become a community historian of sorts and have learned that the past is relevant to our present and futures as we recall the lessons learned. Context is good. Please forgive my use of a prepared text. As all of you know, I am by nature a slow talker, and I have a limited amount of time to say everything that I want to say. I was trained as a general surgeon and practiced in a small hospital setting for 10 years here in my native state. I returned to Pennsylvania for fellowship training in trauma and surgical critical care, then moved back to Maine and co-headed the burn and trauma units at Maine Medical Center in Portland. In 1989, I was asked to come to Bangor to help set up a trauma program at EMMC, now known as Northern Light. So how did I become a breast surgeon? Good question. What you see here today as Northern Light Breast Surgery, a care center within Northern Light Cancer Care at the Lafayette Center in Brewer, is the apex of a pyramid whose base was established many years ago. You will meet the principals within this comprehensive program as soon as I stop talking, if I read the program correctly. And I'm proud to say that in memory, they're still my colleagues, even though I am old. What is this to do with my trauma specialty? During my early surgical training, the treatment standard for breast cancer was the modified radical mastectomy. It was a toned down version of the horrific radical mastectomy that preceded it. At the time, breast cancer treatment lay squarely within the domain of the surgeon. With better understanding of breast cancer biology, systemic chemotherapy and hormonal therapy were added to surgical treatment, and suddenly breast cancer was no longer a surgery-only disease. Moreover, other specialists, such as medical and radiation oncologists, became involved. The treatment of breast cancer evolved to a collaborative and multi-specialty effort. In private practice, I joined in 1989, was the now legendary duo of Dr. Robert Bach and Dr. Tom Palmer. Dr. Palmer had recently retired, and my office hours were instantly flooded with his breast cancer follow-up patients. Meanwhile, my efforts to form a trauma service among a group of dubious general surgeons continued. What I'd learned in my trauma training and practice was that systems development and management were essential. You could not do trauma alone. You fostered and nurtured relationships between hospital departments, such as neurosurgery, orthopedics, emergency services, and the outlying hospitals that referred patients to you. In trauma, where swift assessment and stabilization were paramount, this is frequently a matter of life and death. So I was a board-certified collaborator. As Dr. Palmer's unwitting successor, I began to see a lot of, quote, breast referrals, mostly women who had a breast lump, or more significantly, a mammogram that showed a suspicious density. Diagnostic questions of this sort were routinely referred to a surgeon because the only means of diagnosis at that time was an open surgical biopsy. One day, a rather understandably distressed woman asked, "Why did it take so long to see you? My life and my family's lives have been put on hold." Evidently, the time interval between the original mammogram, the recall for repeat films, and her scheduling for an office visit with me had taken 3 weeks. I was shocked, and when we looked retrospectively at about 50 similar patients, the average wait was nearly the same 3-week period. Something had to change. The answer to the problem reminded me of the metaphorical frog in the pond with a lot of lily pads. To make progress, the frog must jump from pad to pad to pad. But what if the pads were lined up on top of each other, vertically, eliminating the need for the frog to keep leaping from pad to pad? This is the essence of systems management. In the early 1990s, a radiologist from Colorado named Steve Parker began to publish studies on the accuracy of ultrasound-guided cord needle breast biopsies. A short time later, Fred Burbank of California published similarly on a procedure using X-ray guidance with stereotactic cord needle biopsy. So I went to a meeting to learn about these technologies, thinking that the ultrasound version could be carried out in my surgical office setting. How many lily pads would that eliminate? At the meeting, I was horrified to realize that I was about the only surgeon in the audience. This was ominous, a hostile takeover by radiologists. And I know you're listening, Michael Pankow. Surgeons, wake up. Coming back to Eastern Maine Medical Center, I discovered a true hero and a gifted nurse, Elaine Chambers. We worked together and worked out several plans. First, a breast and osteoporosis center to which patients could be referred from all over northeastern Maine for expedited and rapid diagnosis. A plan that all image-guided breast biopsies would be reviewed weekly for accuracy and correlation with the clinical setting. This latter service, the correlation conference, was attended by radiology, pathology, and surgery, and was made available by internet to several outlying hospitals and practitioners. The final step, the creation of a multi-specialty comprehensive breast cancer care service, was left to the capable hands of my colleagues, whom you will hear from shortly. So there you have it, a brief look back into the past that informs our present and inspires our future. For me, the completion of this pyramid has been the hard work of a dedicated team that has taken the initial ideas and aspirations, applied their own skills with new science and professional relationships to create a truly remarkable center of empathy and help for people in need. I and they are very grateful. Thank you for this opportunity to talk with you.
Oh, thank you so much, Dr. Horner. What a privilege. I'm just so grateful that we've captured that as a recording. I know that some that couldn't join us tonight will be so pleased that they can watch and take that look back with you. So thank you for joining us. And now we get to introduce two people that you're very fond of. Would you like to do the honors?
Absolutely. It's, I know this is virtual, but at least we're going to see their faces. Susan O'Connor and Kim Lieber, my colleagues as referred to previously. And, oh, this is Cookie. Hi, Susan. Oh my gosh, it's so good to see you. And where's Kim? She's around there somewhere.
Coming someplace.
All right.
See if she's here yet.
Well, so these are the.
She's there.
I'm here.
Okay. Well, my gosh, it's been so long since I've seen you. How you doing?
We're surviving.
I bet you're busy. Anyway, Susan O'Connor was my former partner at Northeast Surgery. We worked together for many years. Kim Lieber came to Bangor a little bit later, and we worked together, all three of us. I remember days with the Maine chapter of the American College of Surgeons, and a lot of great times together. So let's hear what they have to say in this amazing new breast care center concept. Thanks.
Well, Bill, it is wonderful to see you.
There he is. So thank you so much, Dr. O'Connor. And Dr. Lieber, I know you're there with us somewhere. We heard your voice earlier. What we're hoping that we can do is have you both start out by just telling us a little bit about yourselves and what brought you to this area of medicine, and got a few more questions to ask, and hopefully that will help our viewers understand better the future. What does breast cancer care look like going forward? Dr. O'Connor?
Sure, I'll take that. I came to Bangor because Dr. Horner offered me a job. I was very excited that somebody was actually going to hire me to be a surgeon. So, and then I guess I'd say breast surgery and breast cancer chose me, because I came here with just a good general surgery background, but found that there were a lot of people that wanted to see a woman for their breast cancer care or the breast care. And I had Dr. Horner for a partner, and he had a well-established breast practice, and I learned so much from him. And the two of us put our heads together and leased an ultrasound machine and got ultrasound privileges and just went from there. And then when Dr. Horner retired, just like he inherited Dr. Palmer's large selection of breast cancer patients, I inherited a good portion of Dr. Horner's patients. So we have a legacy going on. The more you do something, the more you realize that maybe it found you for a reason. This became my passion, my reason for coming work, my reason for staying late at work. And I love what I do and I hate the disease. And I think that's what we would all say. And then I was lucky enough to meet Kim and realize we were kindred souls, have an institution, Eastern Maine at the time. What was our old name? I forgot. Anyway, Eastern Maine, and administration that had seen the hard work that Elaine and Bill had done and backed our idea of having a breast surgical practice that was interested in utilizing ultrasound and was very interested in creating a different sort of environment for breast care. I guess, and I think that's a good lead in for Kim to start talking about her past and our vision.
So I've always been fond of cancer patients. Trauma was never my thing. I love a good pre-planned, boring operation with relatively standard results. So I always gravitated toward cancer care and considered doing a fellowship in surgical oncology. But after 6 years of surgical training, my husband reasonably questioned how much more training I needed to do breast surgery. And there were no fellowships at the time of my training. So I got an apprenticeship in general surgery with an emphasis in breast surgery, because I too was the first female surgeon available to patients in my community. After 5 years of practice in Massachusetts, my husband and I decided to change our location. We found Maine a wonderful place, and we decided to live where we most enjoyed being. And I was grateful to the community for allowing me to come up here and start practicing, and especially grateful to Dr. Horner for taking me under his wing, despite the fact that we were in competing private practices. So I was very impressed with the collaboration between radiology and pathology and surgery with regard to the correlation conference that had been established, and I routinely attended that. What I introduced, I think, to the, and what I think makes me uniquely qualified to be a breast surgeon is my ability to integrate ultrasound into my care. And what I recognized was that Susan and Bill had already done that. We came to that same conclusion independently. And it's to the benefit of our patients that we can do real-time ultrasound evaluations. And the quality of that care just keeps improving as the resolution of the imaging improves. So much so that Susan and I do the majority of our operations now guided by ultrasound intraoperatively, and no longer require an extra step for that patient on the day of their surgical treatment. As I look forward, I'm reminded, Susan tells me this all the time. She says, nothing that I did when I started my practice is the same as what I do now. And I see that evolution in breast care continuing into the future. And what makes me so excited to be a breast surgeon right now is the fact that the impact of the treatment that I'm providing patients is being lessened, so that the treatment is tailored for the biologic disease with less impact on the patient's wellness. Most of my patients will survive 20 plus years after their treatment. If I can provide that treatment, or the team of providers can provide that treatment with fewer long-term side effects, that is an advantage. One example of that is the change from axillary lymph node dissection to sentinel lymph node biopsy, decreasing the risk of lymphedema in the arm. And we're seeing it in radiation oncology with de-escalation studies. that show that it's safe to eliminate radiation therapy for some patients when you select for them carefully so that they can avoid some of the side effects of their treatment and still get the best outcomes. So I'm really encouraged right now that we're starting to tailor treatment. It's not one size fits all anymore. And I'm so grateful to Northern Light Medical Center for allowing me to participate in the excellence of this healthcare community and be a part of it. It's beyond my wildest dreams of how my career could be, and I'm living my fantasy.
I think the one thing I'd add about the future, and this is probably a good lead into our next speaker, is the one of the huge things that's changed over the, well, I'm not going to give you a number of years since I went to medical school and residency, but shall we say it was a while ago, is the more and more emphasis that we are dealing with people, individuals who have a whole life outside of what we're dealing with, and seeing people as an individual and making sure they feel like that they're not a number in a study, or that they really are individuals to us and very important to us, and trying to create a practice that emphasizes that from the minute people walk in the door to the time we can discharge them 5 or 10 years later. And that there are 5, 10, 20, 30 years, and that there's a lot of survivorship that goes on. And that's, I think that's a new emphasis. I think that's something that's coming up and coming and is part of the future. And we're very much aware of that. And I think that will hand you to the next part of our talk.
Thank you both very much. And that is a terrific segue. It is wonderful, I'm sure, for you to have seen the increase of longevity with your patients, whereas dire cases now have more hope. You're looking at someone who fit that bill, right? I mean, her 2 new breast cancers not that long ago had a very unfavorable outcome. And now I'm counted among the many that get to use the word cure. So thank you for serving women just like me. And bringing us to our next segment, a pre-recorded message from Dr. Dennis and her colleague, Suzanne Chase Davis, who are leading up our survivorship program. Christina, can you roll that pre-recorded video?
So I'm Dr. Elizabeth Dennis. I am a primary care physician, internal medicine doctor by trade. I have been interested in helping people with cancer for much of my career. I started working with one of our physicians here in an outreach site more than 10 years ago, and I continue to do that work. In late 2019, I came here to Cancer Care, so now this is my home. I came here to help the organization develop a survivorship program. So survivorship is, well, it was very new to me when I first started, so I did a lot of learning about that. And what I think really excites me, and what's been exciting, is that I started at the beginning of the process here for the organization. So it's a clean slate. So that's always fun and challenging. But this is a service that hasn't been a part of our center. It's been more, I would say, the recognition of the importance of survivorship care is growing. It's not new, but it is new to our organization. And what's wonderful is that with all of the advances in cancer treatment, there are a lot of cancer survivors, and people are living for a long time, which is wonderful. But we are I guess I don't like to say but because it sounds negative. But as a transition, what is very important that we are now recognizing is that people live with cancer survivors they're a very unique population. So they live with a lot of potential side effects from treatment, and not only physical side effects, but perhaps emotional, spiritual, et cetera, as they progress through or as they move through their journey of having cancer and cancer treatment. So I think that's what really excites me about this work is that it's not a service that we've had before. It's an incredibly important work for people. And I think, I guess just, me, so primary care, my background, I think really makes a lot of survivorship care is helping people to be well after having had cancer and treatment for cancer. So I think my professional background has really set me up to do this work well. So I will stop talking and let my good colleague Suzanne weigh in as well.
Wonderful. Suzanne, please introduce yourself and share us what brought you to this work.
So my name is Suzanne Chasse.
Suzanne, we're having a little trouble hearing you.
Oh, dear.
You can come closer to the mic. That might help.
How is this?
That's a little bit better.
Oh, okay. I don't know how to adjust the volume, so.
Oh, we can hear you now. I think that's great.
Okay. So my name is Suzanne, and I started out in oncology. I knew I wanted to be in oncology when I went to nursing school. And I started out on Grant 6 at Eastern Maine Medical Center and had a great experience there for a number of years and came here in 2017 to start working more as a primary nurse for one of the doctors or two of the doctors. And since then, the opportunity has arose to work with Dr. Dennis in survivorship, which I'm very excited to do. We certainly have a population, our survivors, like as she was talking about, certainly have needs that maybe a primary care physician would address and maybe they wouldn't. But we certainly have the vision to be able to recognize late effects of treatment, long-term side effects that maybe we can help mitigate. And really, it's all about trying to improve clinical outcomes for our patients and improve their quality of life.
Excellent. So let's imagine that those that are watching are not familiar with what it looks like to be a cancer survivor. Could you help those viewers understand what is a survivorship program, and in a practical sense, what does it look like for a patient receiving the benefit of a survivorship program?
Do you want me to start?
Yeah, this is to the two of you, whoever would like to start. Oh, you're on mute, Dr. Dennis. The joys of technology.
Sorry about that. So cancer survivorship, again, a very big, broad topic, but if we talk about first what a cancer survivor is, if we look at the broadest definition, which I think is being embraced more and more, is that a person is diagnosed with cancer and they live their life, and at some point they die of something. So survivorship care, and then if we talk a little bit about oncology care, so the care of a patient with cancer, people are diagnosed with the cancer and then they receive medical care appropriate to their diagnosis. And then at some point, if they, and that's where it makes it a little bit more complex, we'll use a more narrow definition, meaning that a cancer survivor is a person that is being treated with what we call curative intent. So based on our medical understanding, a person had cancer, they were treated for cancer, and the cancer has gone away. So traditional oncology care or care for the patient with cancer addresses really their medical, what's your diagnosis, what's the appropriate treatment, how do we help you get through that, and then you are living your life beyond that. What survivorship care I think really does or should be doing, and this is what we're trying to do, is look at folks from the beginning of diagnosis and try to incorporate in a multidisciplinary way all of the supports a patient might need as they're moving through this journey. So this is not just medical, so not just physical symptoms, but behavioral health or emotional challenges, financial challenges, practical things like how do I parent and have cancer? How do I have cancer and have a job, et cetera, et cetera. And then as people move through and they have completed treatment, really trying to, where people kind of letting the dust settle and then reincorporating or not reincorporating, but yes, I suppose that's an okay word, basically getting back into life again. And how does that work? And how can survivorship services support people as they're making that transition after having completed treatment? So what we are, what we're trying to do, and Suzanne is, thank goodness, a new member of our little team. So it's the two of us now, and we are trying to really proactively connect with people rather than wait until they're 5 or 6 or 7 years out of treatment. Really identify people as they're diagnosed, follow them through their treatment course, and then start proactively introducing survivorship and survivorship services services to people. So I think I will stop there, and then you can expound if you would be so kind.
Sure. So like Dr. Dennis said, we are trying to be proactive to identify especially the most acute patients that may need services. And again, that could be challenges of side effects. It could be financial toxicity. It could be a number of different barriers for them and obstacles. The loss of work. Many people have to stop working to get treatment. How do they reincorporate their lives? Like Dr. Dennis was saying. So we have set up a database, and certainly we have a number already on there. We have over 200 patients already in our database that we are following and reaching out to either do a chairside RN visit if they're getting IV treatments, or we're trying to make sure they get in for at least one visit with Dr. Dennis in surveillance, or once the patient has started, say, a maintenance therapy. So we are reaching out. We're doing treatment summaries and care plans for them. Basically, we're trying to wrap around the whole patient. When they finish their acute phase of treatment, quite often they're at a loss. What do I do now? Before, they were very proactive. They were having surgery. They were maybe getting IV treatments. And all of a sudden, we kind of just say, okay, we're kind of done. I mean, we're going to follow you. But now they get it in their head that maybe they're just going to go home and wait and see if it's going to come back. So we try to wrap around the patient, trying to educate them on things to look for, whether they're physical symptoms, whether they're emotional reactions, and then try to fill in those gaps with services.
What an exciting and wonderful thing to be able to be providing to patients. And I think if you would help me understand if this is the correct way to say it, that survivorship in a nutshell is best described as a way to support the whole person, mind, body, and spirit, in every way that cancer may impact a person's life, livelihood, family, and social circle. So the survivorship program is able to assess and address all of those needs. Would that be a correct statement?
We certainly are assessing them and trying our darndest to address them. Resources are limited in some areas. That's not news. Everybody knows, I think, or most people are aware that especially counseling, mental health services are lacking, not only in Maine, but across the country. So we struggle a little bit with that, but we are working on things and coming up with a few plans meeting with some organizations to try to see if we can make more services available for our patients.
Well, that's a great segue because recently we did receive some very strong philanthropic support, which has allowed for the survivorship program to grow some. I know we have a lot of plans. You both have great vision for the future as to how you want to support those patients. Having someone on our staff that is trained in oncology that could meet the mental health needs of patients is certainly on the wish list. So what would you say to those who do support us philanthropically? Is there anything that you would like to particularly say to those folks that might watch this now or in the future who may be considering helping us?
So if you don't mind, I'll start again. The
Sure.
doctor butts in. So, so Suzanne is an example of a huge example of how philanthropic dollars have helped this program. As I said, I started my efforts at the end of 2019, and I was a team of one until recently, so this year. And since, I was certainly doing things in my survivorship work, but I would say the pace of how we have been able to advance things has changed dramatically since Suzanne has been added to the team. We are, and my goal has always been to be proactive, but I really could not pull that off by myself. So now that Suzanne has joined, I would say we now are in a position and we are doing proactive work rather than, I guess, reactive. So not just catching people sort of along the trajectory, but identifying people as at the time of diagnosis, as we said. So that's been absolutely amazing. I think it's allowing us to start to dream. As you were great, Jenny, with that high level summary. That's exactly what we're aiming for. That takes resources, people resources, et cetera. But that's really what I strongly feel, and this is what keeps me going. This is what we should be doing for our patients, and we're just starting to move and shake, and that's been with people in the community that have been generously donating. So hopefully that answers your question. So a big thank you, and we will always talk to anybody that would like to help us advance our ability to help people in this way.
Absolutely. And I would just like to add that it's hard to describe the effect that the survivorship program has on individual patients, because sometimes it's just the relief that you see come over the patient's face when we are able to meet a need or take down a barrier for them, and or treat a side effect that suddenly crops up. Not that the oncologists don't do that, but sometimes it takes the right questions to get them to speak up. And survivorship is all about meeting their needs, and just to see their face, that relief of, you mean you can do that for me? You mean you can do that referral, or you're going to get help for me, or I can try this for say neuropathy, something like that. It's hard to describe, but those moments when you see a patient's reaction and you genuinely see the stress level kind of just decrease is so meaningful. And I certainly wish that every donor could see that, because it's powerful. And I thank you. I thank everybody that's contributed to this program. Survivorship is on its way, and we're pretty excited.
I hope you enjoyed that as much as I have, and I've watched it a few times. Our next segment is going to be a pre-recorded message from Dr. Sinclair and Carla Mancini, showing us a little bit about precision medicine, the hope and progress that it offers to our patients. And then following their pre-recorded message, they'll join the panel for a Q&A. So if you have a question for any of the panelists that we've had today, even those that were pre-recorded, which unfortunately, Dr. Dennis is the only one unable to join us tonight. please do begin by putting those in the chat. We'll monitor those and we'll be sure to add them. So go ahead, Christina, and roll the next video, and then we'll open it up to our question and answer segment. What defines precision medicine?
Yeah, so I can start. So, I mean, there's a lot of different definitions out there. I felt like this one really made it clear that precision medicine is really a form of medicine that uses information about a person's genes or proteins to prevent, diagnose, and treat disease. More specifically, in cancer, we think of precision medicine as utilizing specific information about a person's tumor to help make a diagnosis and a treatment plan. So when we talk about genomic tumor testing, this is precisely what we're talking about. Some examples of this would be HER2-positive breast cancer. I think most people are familiar with that subtype of breast cancer. Trastuzumab targets HER2. So this would be an example of precision medicine. ALK mutated lung cancer, EGFR mutated lung cancer, microsatellite high cancers. These are all examples of genomic and molecular testing that we utilize every day in order to improve treatment, and patients have significant improved survival with these treatment options.
That is very helpful and very easy to understand. Carla, is there anything that you'd like to add to that?
I don't think so. I think that's perfect. I think people will clearly understand what that means.
Mm-hmm. And for those who hear precision medicine and then they hear the word genomic, it's important that they understand it's different than genetics, isn't it? Can you help them understand that clarifying point?
Yeah, so that's very common. A lot of times when you talk about genomic tumor testing, patients will say, "Oh yeah, I already had the test. I don't have the gene." So that's a common thing that we'll hear. And then when I hear that, I immediately realize they're talking about a genetic test to look to see if they inherited a particular gene that would increase their risk of a particular cancer. So genomic tumor testing is different than germline testing for hereditary disease. So genomic tumor testing is just like it sounds. It's a test on the tumor. And this is something that we utilize very frequently now in the clinic. We really feel that most patients with advanced cancers should have a genomic tumor test in order to really maximize their options, not only for standard therapies, but also off-label therapies and certainly enrollment on clinical trials.
Excellent. Anything you'd like to add to that, Carla?
No, I think that's perfect.
Excellent. Okay, well, now I'm going to turn to the two of you for a very happy subject in that we received philanthropic support. It's hard to talk about because one of the two members of this beautiful couple is no longer with us, but before Kathy Jarrow passed, she was the driver here with her husband and very passionate in regards to research. Could you share a little bit about Jim and Kathy Jarrow's investment in precision medicine for Northern Light Health Cancer Care and what that means?
Yes, I mean, this was, an extremely generous gift that we received from Jim and Kathy, and it has made already a huge impact in what we're doing for patients in our research program. And Carla can speak more to this, but we, part of the upfront gift was they were very generous in providing us the funds to hire a research nurse that would be dedicated to precision medicine clinical trials and helping us sort through everything that goes into ordering, reviewing the genomic tumor tests, and screening for our clinical trials. So we have happily hired an excellent research nurse for this position, and she'll be starting very soon and working directly with Carla who'll be helping to train her. So she has oncology experience, which is what we were looking for. And she doesn't have direct research experience, but she's very excited and she really wants to learn research. And so in part of all of this, you know, as you can imagine, coordinating all the genomic tumor testing, getting that information and utilizing it takes a lot of time. And Carla has been able to work with us and institute a much more efficient process for this, which I think is going to significantly improve our enrollment on trials. And so I'll let Carla explain, you know, what she has done to institute this improvement in our process.
So what we did was we looked at the process that was currently in place, and it involved the patient advocates sending out the requisitions for each of the different types of testing that we can do for patients, depending on their diagnosis or whether they have tumor tissue or we need to use blood. And what we found was, because the patient advocates are not clinical, they struggled with filling out these requisitions, and they ended up going back and forth to the physicians for questions. So it delayed the testing being sent out and therefore the results. So we put a process into effect where our new research nurse, Amber, and our current study coordinator, Rong Zhang, will be the ones now who receive the order from the physician for a specific test, and then we will complete that requisition. We will get in contact with pathology and or the lab, send out this sample. We will follow the sample for when it is received, when it is resulted. We will get those results directly to the physician and have it scanned into their chart. And at the same time, once we get those results, we will be reviewing every single result for participation in clinical trial. And this way, every single patient who has a test sent out of this building will have a review of their result for possible participation in trial, which is something we've never done in the past. So I think it will help us with enrollment, but in the long run, it will certainly help patients. When these results come in, they do list the clinical trials that the patient may be eligible for. So even if we don't have one in Maine, we can certainly refer the patient to a clinical trial if they're interested outside of Maine.
That's incredibly exciting. I mean, knowing the patient population and having been one, it's daunting when you hear a cancer diagnosis. And when I was diagnosed, if I wanted access to anything like this, I had to scour the very new internet and hope that I found myself in the right place. Often it was the NIH, which is meant to serve its professional population. It's not a place typically that the average person goes for information, and it was not easy. So imagining myself now in the shoes of a patient, I'm just so buoyed by all of this. So thank you for explaining all of that. It's such a wonderful thing to directly understand how, one donor, one couple can make such a profound impact on our patients and the future of patients really everywhere, right? The more clinical trial activity that we have, the better the world is for it. And even this week, big headlines in the world of cancer treatment and crazy results in a couple of different types of cancer. So it's just a wonderful thing to hear about. And I'm hopeful that those that watch this now while we're doing this presentation for the library or later will be as inspired and perhaps even motivated to decide to do something meaningful to help continue to further the advancement of patients and their futures. So, when you think about patients and how precision medicine has made an impact in their care, do you have any other, last closing thoughts that you'd like to share in regards to how the lives of patients are being impacted by this new era of treatment?
I would say that precision medicine really has allowed many patients, even before we called it precision medicine. I mean, this is a relatively new term, but many years before we called it precision medicine, it has allowed many patients to receive targeted therapy to treat their cancer. And the cancer that I mentioned earlier in this talk, you know, HER2 positive breast cancer, ALK mutated lung cancers, EGFR mutated lung cancers, you know, this is all precision medicine. It's just we're doing it on a much larger scale now, thankfully, because certainly this is the present treatment of cancer, and it's also the future. Most treatment trials are now incorporating genomic tumor testing. It's embedded in the trial. And the reason for that is really to improve our understanding of complex biology of cancer. And this information is invaluable, and it does lead to improvements in treatment for cancer patients. So when patients enroll on a treatment trial, you know, not only are they getting, you know, a treatment that is actively treating their cancer, but also by donating tissue or blood samples, we're learning a lot that will impact treatment for many years to come. And we need patients to continue to do this. That's how we make progress. And since the beginning of this year, in January, we've enrolled close to, I believe our number's 33 patients on clinical trials, which is a lot for a community center. So we're very proud of that. It's not easy to put a patient on a clinical trial. So we're looking forward to even more enrollments throughout the remainder of the year. We've had the opportunity to discuss multiple genomic tumor results at molecular tumor boards through our collaboration with Jackson Lab through the Maine Cancer Genomics Initiative. And this has been an invaluable tool for us to be able to network with experts in the field to help better understand the results and help patients the best that we can.
Thank you so much for that. Carla, is there anything that you'd like to add?
No, I think that Dr. Sinclair is right on. We're seeing it happen every day. We're seeing patients get targeted therapies more and more every day, and we're also seeing them live longer and respond to these therapies, and also have maybe a lesser type of side effect from your typical chemotherapy.
Well, I hope you enjoyed that segment. We're now at the wonderful time when we can bring our panelists together and take your questions. So if you have a question for any of our panelists, please do put them in the chat. We've got some great comments that have come this way. Karen Stanley says that she can attest to the professionalism and care of Dr. Horner and Dr. O'Connor. My most sincere thanks. CCOM is a very special place to me. For those of you who maybe haven't been around as long as some of us, you may not recall that it used to be CCOM. It was Cancer Care of Maine way back in the day. So Christina, Amy, do you want to bring our panelists to the screen and we can have our Q&A with Dr. Sinclair, Carla, Drs. Lieber and Dr. O'Connor? Excellent. We're bringing you all on. Look at this, technology is working. Well, I have a question, since there isn't one in the chat just yet. I would love to hear from all of you. If you could just share something that would inspire us. When you think of a day in your life of treating our patients, is there a certain incident, a certain outcome that you kind of use to recall when days are difficult? And I'm kind of imagining that most of your days are probably difficult during this time in history. So do any of you have a recollection you could share?
I can tell you one of the things that's incredibly exhilarating is when I see a patient, and often we're the first people to see a patient and tell them they have their cancer. And I see a patient with very aggressive disease, you know, involves lymph nodes, it's big, it's aggressive, it's come on suddenly. And we're able to, instead of jumping right to a very aggressive surgery, I can hand them to Sarah and her colleagues and do the genomic testing, do the testing, come up with an approach that utilizes all of our strengths and treat with chemotherapy or HER2-directed therapy or some combination. And then they come back to me after they've gone through that and it's gone. You know, I can look at the breast, I can feel the breast, I can look at the breast with ultrasound in the armpit and say, wow, I don't see it. Then we can go to the operating room and do a smaller surgery, extracting just a little bit of breast tissue, just a lymph node or two, to prove it's gone, and to prove that, you know, this incredibly targeted, amazing therapies we have now have worked. And my role has almost become obsolete. You know, I'm just proving that everything on my oncology or radiation oncology, everybody's work has done. And I look forward to the time, maybe it'll happen before I retire, maybe not, when much of what I've done will be of historical interest only. It'll be like the old ulcer surgeries nobody does anymore, but we all had to learn about in medical school. So I'm thinking in 20 years from now, some medical students can be tortured learning the history of breast surgery. So I can't believe we did that. So that's what I'm looking forward to and what's come so far. And that's a pretty neat moment when I can show people in my office that ultrasound with just the clip there and no tumor.
I would definitely say that's exciting. I know that helped fuel my hope for my own personal future when I was first endeavoring to take Herceptin, and I spoke with a patient who had taken it before me and had a visible tumor. Her cancer had metastasized outside of her breast into a lymph node that could be seen in her neck, and that she was like that, Dr. O'Connor, where the drug was received and the tumor just seemingly disappeared. And that gave me quite a bit of hope that I did not have. So yeah, it must be amazing to see that each and every day. Does anyone else want to add to this conversation?
I think you're muted, Kim.
You're muted.
Thank you. There's always something to be hopeful about. And, you know, precision medicine is helping not just our patients with curable cancers, but it's prolonging and improving the life of women who present with metastatic disease. And I can think of a couple of women who I've treated over the last few years that came to me for biopsy of cancers that were very advanced and metastatic. A young woman who had just immigrated to the United States and married her husband, only to find out that she had breast cancer that had metastasized to the liver. Another woman who had been living and working with a locally advanced breast cancer that she just couldn't afford to take the time to treat, didn't have insurance, and it had gotten so bad that she had to go to the emergency department. My role in their care was simply to diagnose. It's the precision medicine and the medical oncologists that have provided them treatments, and they are now living and flourishing with metastatic breast cancer. It's tremendous. I agree with Susan. I look forward to the day that I will be obsolete. My role will be simply as diagnostician and to salvage when cancers return. I mean, that's the direction it's going, and it's so amazing. It's so thrilling, and it's the smart doctors like Sarah Sinclair who know how to do that stuff. Surgery is treatment of the past. Precision medicine is treatment of the future.
Yeah, I would say you're right about that, Kim. There's a lot of patients.
You're the smart doctor?
No. Well, I am a smart doctor. Yes, I will say that I agree with that. No. I hope so. But what I agree with is your statement about patients living with metastatic disease. I think it's an understatement to say that it's devastating for any patient to develop cancer. And it's even more devastating to have a recurrence and develop metastatic disease that's incurable. So I would say that's the most challenging part of my job. Is to help guide people through the process of living with metastatic disease and understanding that it's incurable and we don't know how to estimate perfectly survival. And it's very difficult to live each day not knowing that, am I going to be here next year? Am I going to make it to my grandchild's wedding? You know, am I going to make it to my child's high school graduation? So that's the most challenging part of my job. I would say, even beyond learning the medicine, which is extremely challenging, is how to support patients through that, and how to continue to find new treatments when something isn't working. But every once in a while, we'll have a patient that surprises us with metastatic disease. And so I wanted to share a couple of examples. I have a patient who came to see me, it's been almost 5 years, with metastatic pancreatic cancer. So right out of the gates, she had metastatic disease. She'd already had her consult at Dana-Farber even before she walked through the door to meet me. And she's still alive 5 years later. And her husband just sent me pictures of the garden they've planted and all that they're doing, because she's on a treatment break. So I have no idea why her disease is responding so differently than other patients with metastatic pancreatic cancer. So this highlights that we just don't know. There's so many things we don't know. So of course I did the genomic test. I did everything I could think of, and it's a mystery. I have no idea why this patient can continue with metastatic pancreatic cancer for 5 years and take treatment breaks and garden and swim and send me pictures and write me letters and send me cards. I don't know. And so that's an exciting thing for an oncologist, to think that there's so much that we don't know. And that's the draw to precision medicine and genomic medicine, and the elusiveness of the biology of cancer. We don't know. We want to know. We want to understand why. We want to unlock that mystery. So it's every day is a new challenge, and we never stop learning. And the best way to learn is through clinical trials. The best way is well-designed clinical trials, and trying to get as many people, a broad sampling of the population on trials, not just patients in the academic centers, because that is not reality. The majority of patients are treated in the community, like our community. And we offer a lot of options for patients with trials, and it's extremely important to get these patients on these trials, because there's no way we're going to learn, and there's no way we're going to, look back and say, I can't believe that's how you treated breast cancer, if we don't continue to do this. And it is an effort that for everybody. It can't just be one person. It's not just the research staff. It's every single person that touches a patient. And it's done through education, because a lot of patients come to us and they have no idea what we're talking about when we mention that we have clinical trials. So there's a lot of education that goes into it. And we have learned so much in the past 5 years in terms of understanding genomic medicine through our participation with the Maine Cancer Genomics Initiative. So I can't say enough of what I've learned personally, and how rapidly treatment changes in oncology. So 10 years ago, what we did 10 years ago is, it's old news. So when I think, geez, I've been here for 12 years, it's my only job I've had, I think, I'm not old, I'm still, in the prime of my career. I look back and think, everything I'm doing now almost is different than what I was doing. I have to go back to school. But coming to work every day is coming to school. So, and we work with an amazing group. I can't say enough about Susan and Kim, of how much they have impacted the community. It's really moving to see how dedicated you guys are. So thank you for everything that you have done over the years. It's hard to match that, but we try.
Thank you so much for sharing that, Dr. Sinclair. I see a message from Dr. Panko saying, enjoy seeing all of my former colleagues. Thank you for joining us, Dr. Panko. We're glad you're here. What an amazing team that we have here at Northern Light Cancer Care. I hope that you as a viewer have gleaned what we are hoping that you'll see, This is a tremendous team that works tirelessly for you. There's Dr. Sinclair at 6:37, and she hasn't left her office, and neither has Dr. Lieber or Dr. O'Connor. And it looks like you too, Suzanne Davis, you're there as well. And I wish I could say that that's not common, but I know them, and I can tell you that is their MO. That's how they serve you and they serve our community. They serve ours that I don't know that many of us could do. So your philanthropic support and the way that you come alongside them really does matter. Whether your gifts are small or great, they make a difference in the lives of patients each and every day. And it'd be my privilege to have a conversation with you. We are going to follow up with this event. We've got an email that's going to go out to you. We'll have these videos should you want to share them with friends, and always the ability to share with you new news in the future. So I want to thank you all for being a part of this panel, contributing to our really rich dialogue about hope and progress, and what a tremendous impact Northern Light Cancer Care and breast care surgical oncology is making in the lives of patients each and every day. Thank you all.
Thank you, Jenny.
Have a good night, everyone.
Yeah, I think we should thank Jenny for everything she does.
Yes.
Everything she does. An unsung hero of the cancer community.
Well, it's a privilege to be a very, very grateful patient and serve you every day. You do the heavy lifting, and I'm happy to be here. Thank you for that, everyone.
Nice to see you, Mike. Nice to see you, Bill. Everybody else.
Bye.
Bye-bye. Nice to see you all.